Hello. Before we get started with our next session, I wanted to remind everyone that Dr. Jessica Gold, along with Alex Salser, is meeting with our teens in the team room to chat with them about coming-of-age topics. Wink, wink. If you have a teen, this should be an excellent roundtable discussion for them to enjoy. Also, if you would like a more hands-on session, right now, Glenn Knopfsinger is leading a knife skills roundtable in the Black Box Theater down this hallway right here. And this is a first come, first serve for 5 to 6 people, but of course, if there's more people, you're welcome to stay in and observe and participate in that. Without further ado, I have the honor of introducing Dr. Amanda Barone-Pritchard. She happens to be our family's metabolic clinician, and Amanda Barone-Pritchard is an assistant professor of pediatrics at University of Michigan Health in the Division of Pediatric Genetics, Metabolism, and Genomic Medicine. Dr. Pritchard attended the University of Pittsburgh School of Medicine before completing pediatric residency at Lurie Children's Hospital in Chicago. She then trained in medical genetics and genomics and completed a medical biochemical genetics fellowship at the Children's Hospital of Philadelphia. She currently practices pediatric genetics and biochemical genetics and has research interests in delineation of new genetic disorders and treatment of genetic diseases. She has been involved in several clinical trials for inborn errors of metabolism. Dr. Pritchard is also an enthusiastic medical educator and serves as program director for the Medical Biochemical Genetics Fellowship and associate program director for the Medical Genetics and Genomics and Combined Pediatrics, Medical Genetics, and Genomics residency programs at the University of Michigan. That's a mouthful. Today she will be discussing who's who and what's what, navigating hospitalizations for pediatric and adult patients. We really appreciate Dr. Pritchard for taking the time to be one of our lead contacts in Michigan this year as we plan the conference, and for taking the time to share on this very important topic. I can personally say she's wonderful talking to our kiddos and has been a really great addition to our care over the last year. Please give a warm welcome to Dr. Amanda Pritchard.
Thank you so much. My children brought something home to me, so I'm hoping my voice will hold out for the talk today. But I thought it might be nice to talk about hospitalizations because they can be such a crazy time for families, and there's just a lot going on. There's a lot of people on our care teams, and it can be really confusing to know, who's who and what's what, hence the title. So I'm hoping to hit on some of those things, and I realize I'm your last talk before lunch, so I'll try and be cognizant of time as well so that our stomachs don't get growling here. So I think if you or your child has a fatty acid oxidation defect, there are some things you can do, hopefully before you ever need to go to a hospital, to make the process easier, and that is to know who you're going to call. Often if you have, I couldn't help myself with a Ghostbusters reference, probably showing my age, but if you have an emergency letter from your metabolic team, definitely having that number saved in your phone, take pictures of it on your phone. Sometimes we lose paper, but everyone always has their cell phone these days. So know who you're gonna call. And similarly, your PCP is an important partner in care as well. So depending on the situation, having a sense, talking with those providers in advance, well, should I call you first, or who should I call first? Most metabolic docs would say, probably call your metabolic doc first, and then we'll tell you if it's something that you should reach out to your PCP about. If you are in a situation where you're thinking you might need to go into the hospital, be prepared, or as prepared as you can. And I'd often recommend that you have any of your supplements or your child's supplements, MCT oil, etc., triheptanone, those things may not be on hospital formulary. Same with specialized metabolic formulas or medications. So if you can, pack those up to bring along with that emergency letter if you have one. Okay, so you've talked to your team and you're headed in. What goes on next? So first, where are you headed? That's a logistical question too. And the answer to this may depend a little bit on where you live and how you or your child is doing in terms of your health. Obviously, if anything scary is going on, 911's your best bet, right? But often there's this middle zone of, Johnny's vomiting, but he's doing okay right now, so we're safe enough to drive in. That can be a discussion with your care team as well. So if you're in an ambulance, they're probably going to take you to the closest hospital. But if you have two that are equidistant, you could certainly ask the ambulance drivers, hey, we actually follow at this hospital. Can we go there? If you're traveling, I always recommend you talk to your metabolic team in advance, especially if it's a long trip or an international trip, so that you can have in mind what hospital you would go to should an emergency arise. I always say it's a small world in genetics, so likely your metabolic team may know the geneticist, in X, Y, or Z state. And then if you don't know, where to go, or something comes up that you weren't prepared for, generally I would say if you're a parent taking care of a child with an FAOD, a children's hospital is going to be a safer bet in that they may be more experienced with rare diseases, genetic conditions, though they may or may not have a geneticist. Or if you're not a kiddo, just kind of your larger academic centers may be more likely to have had experience with these types of diagnoses before. So your first stop when you get to the ER is going to be triage. And you may hear me use ER and ED interchangeably. Some people call it emergency room, emergency department. So triage, you're going to check in, you're going to register, look at your insurance stuff. Great. Then the nurse is going to ask your chief complaint, get some vital signs. And this is, if you take nothing else out of this talk, and I hope that most of you have not had to go to the ED, but if you have, make sure to tell them about your child's metabolic disorder, because what that nurse that sees you is assigning a triage number, and that triage number determines how quickly you get seen. And if I'm looking at a 5-year-old kiddo who seems to be, talking to mom and dad, maybe playing on his iPad, whatever, but the chief complaints vomiting, but his vitals are stable, that's actually going to be triaged pretty low, which means you might have a long wait. Now, if someone's looking at that same 5-year-old kiddo, same complaint, playing on his iPad, same exact thing, but he also has a fatty acid oxidation defect, that's going to bump that triage number up much higher and get you seen more quickly, because obviously the risk of decompensation, the risk of things getting worse is concerning in our metabolic patients. So again, my one takeaway, to make sure you throw that diagnosis out there. Obviously, if it's your home institution, there might be some documentation in the EMR that's going to help them figure this out, but especially if you're on the go. Sometimes they can check your glucose level in triage too. So if your child's somebody who has a tendency, you or your child, tend to drop your sugars, you could always request that or make sure to mention that. And then if you have a long wait, I would definitely encourage you, if you're worried about how you or your child is doing, to go back up and say, look, I think he's getting worse, or I think this is happening. Before you hit that ED room, they don't really know you and they don't know your child, so you are the best advocate for your family. Okay, now you're going to start meeting all these different people. You finally have a room. Hopefully your wait wasn't long, but you're going to have an ED care team, and that's likely going to be these people, but this may vary by institution. So you're going to have a nurse. That may be one of the first folks that you meet. Then you're going to have likely a resident or nurse practitioner, especially if it's a teaching hospital. And then kind of above that is an ED attending physician, and there might also be a fellow. So you may have 2 or 3 doctors kind of coming in and out, and the resident or nurse practitioner, kind of often the first doctor that you meet, is probably the one that's going to have the most face-to-face time with you. They're probably going to be the ones putting in the orders first, but they're being overseen by that fellow or attending, so the buck kind of stops with them, so to speak. So I think all these people want to work together to give you the best care, and it's just important to recognize that there are different levels of expertise involved. Your resident is often somebody who's, what is a resident? A resident is someone who's completed medical school, and they're in the next step of their training. If you're in an ED, that's often going to be someone who is a pediatrics resident, internal medicine resident, a med peds resident, or sometimes even emergency resident if they're in an emergency training program. So even then, you have different backgrounds that these providers are bringing, and frankly, different understanding and experience of metabolic conditions. So that brings us to, I guess just to say now, your geneticist may not be there right at that moment, right? So that's where your emergency letter and having your ED team contact the genetics team can be really helpful. And we're usually very happy to help ERs, navigate what needs to be done for our patients and how to keep everyone safe. So In the ED, you're probably going to have some labs drawn and an IV placed. That's going to be pretty standard protocol. If you're a difficult stick or your child's what we call a difficult stick, meaning people always have trouble finding that IV, let people know about it. Again, I encourage you to advocate as much as possible to try and keep things as minimally traumatic as we can. There are some things that can help with IV placement. So there's this Buzzy Bee device. Has anybody ever seen one of those or had one of those used? I see a couple hands. So it's basically this little vibrating bee. Obviously, it's very cute looking. If you're a child, hopefully it's not a scary bee. And it can kind of help distract. There's actually studies that show it can help distract from the pain of IV placement, and it provides this buzzing sensation. So that's a non-pharmacologic intervention that can really help. We also have child life specialists in certain emergency departments, and I'll come back to them, but they're providers trained in helping to make hospital stays less scary for kids. We can also use things like lidocaine or EMLA cream. That does take a little while to numb the area. So if someone's really sick, frankly, there might not be time for that sort of thing. But if someone's doing okay, it might be worth asking. And then there can also be little injectable lidocaine they can use at the spot of IV placement as well. So those are some things that you could ask for or try out if you need to. Ask your nurse if you or your kid is allowed to eat. So sometimes in the ER, they love to make people NPO and say, oh, you know what, nothing to eat or drink till we know what's going on. So perhaps just worth asking before you start having a snack. And then theoretically, the emergency room team would call your metabolic team to have a discussion about next steps in care. And then based on all of that, everyone will decide, okay, is this patient going to stay here or is this patient going to go home? And I wish I could say that this was a quick process, but if you're headed to the ER, I would say anticipate several hours and sometimes even longer depending on weights. So just be, mentally prepared, buckled up. If you have time, pack a change of clothes, pack some things to do because nothing happens as fast as we might imagine or would like. Okay, so let's say things play out such that you or your child needs to be admitted to the hospital. Now you're going to meet even more people, all right? It's going to be kind of wild. And I will say that it is totally okay to ask people, who they are on your team and have them remind you. We don't expect you to memorize everybody's name and everybody's role, especially when you might meet, 6 doctors and 4 nurses throughout the course of the day. So again, you'll have a bedside nurse, and then in most teaching hospitals, you'll have a resident. So again, that's somebody who's probably training in pediatrics, internal medicine, et cetera. I put first contact because the resident is usually, when your nurse says, I'm going to call the doctor, they're usually going to call the resident. That's because our residents are in-house like 24/7. They're the one that's available. They're around to come to your bedside no matter what. So they have a really important role, but the resident is also kind of communicating with the other members of the team. So your resident is likely talking to, if you have one, a biochemical genetics fellow or genetics resident, and then even higher up on the food chain, so to speak, is the attending physician. This varies by hospital. Your attending physician might be somebody who's what we call a hospitalist, so either maybe a pediatrician or internal medicine doctor that specializes in hospital care, or your attending physician might be your geneticist. This depends on the institution. A geneticist might also be consulting, meaning that they're not the ones making all the final decisions, but they're in discussion with the attending physician. So again, it's a lot of people, and it's totally okay to ask, who's who and, what their role is on your care team. Spending a day in the hospital, though not fun, does tend to have a bit of a rhythm to it. And so often labs may be done in the morning. They can be done other times of day too, but it's a pretty common practice to have labs drawn early morning. They're often drawn like really annoyingly early. And there's kind of a reason for that, which is that earlier they're drawn, then your medical team can make decisions for your care based on having those labs back. But it's also like really unfortunate that sometimes means waking up you or your child at like 6 a.m. to get a lab draw, okay? We don't do it to be mean, we do it because we need the data to make decisions, but it's not ideal. Nurses will be checking in regularly. They'll be checking in as they change shifts too, so you'll meet new people then. resident or med student may come in round early in the morning, so they may check in on you. Sometimes they even sneak in while you're sleeping and sneak back out, just have a quick listen to heart and lungs, that sort of thing. But then you'll see them again. And then rounds happen, and rounds can vary in how that happens from place to place and frankly day to day. But rounds is when the whole team checks in on the patient, talks about the patient. In an ideal setting, or what we often like to do in children's hospitals, is do what we call family-centered or bedside rounds. So that means you're gonna meet all these doctors on the team. There might be a pharmacist, a case manager, your nurse, and everyone's gonna get together and huddle and talk about you or your kiddo, and come up with a plan. And I think an important thing to know on rounds, which I think can be kind of confusing, is that the person presenting the case is usually somebody kind of lower on the lineup. So that could be your medical student or your intern or resident. And so don't panic if the med student or resident suggests a plan that you as parent or patient are like, whoa, that's like never what we do. Don't panic, just like hold tight. Wait till the rest of the team rounds out that discussion, because often the plan will kind of evolve as everyone talks about the patient to come up with something that makes sense for everybody. Days can be slow, so ideally bring something to keep yourselves occupied. There's often TVs, but if you're feeling well enough to read things or do things, it can help to bring those along. So I kind of alluded to the number of people on rounds and already gave away that the junior members tend to present the case. We love when families ask questions on rounds. The only thing I will say is that, sometimes your medical team may have a lot of time to spend with you, and sometimes they may have a lot of families to get to. So if you do have more questions and you feel like you're not getting enough time with the doctors, just say, hey, could you come back after rounds and talk to me some more? We always want to make sure we're answering everyone's questions, and sometimes just in that big group of rounds may not be the best scenario to do it. So we're always happy to come back. So now I'm going to go through some of the other team members in the hospital. So I know I've already mentioned like 10 people, but it turns out there are even more folks that you may encounter, and or this list is partially so that you guys know things you could ask for if you think it might be helpful during your hospital stay. So there is a thing called animal-assisted therapy, or you'll often hear about the therapy dogs. There's some lovely golden retrievers that walk around our institution. I forget if this is Anna or Fawn pictured here, but if you or your child or someone that's calmed by the presence of a dog, you could totally ask, hey, are the therapy dogs around today for a visit? Switching gear from that, I went for alphabetical order here, so if this seems chaotic, that's what's going on. Case manager, so these are often nurses, but not always, that help coordinate discharge needs. So they're gonna work with your insurance to make sure the hospital stays covered. They're gonna help you get any durable medical equipment you need at discharge. So let's say now you're going home with an NG tube or some other device that you didn't have before. They'll help you get all that set up. So that's somebody that you'll see kind of on rounds, and then as discharge comes closer, they'll have more conversations with you. Most hospitals have chaplains of some sort. So these can be either non-denominational spiritual leaders, or in bigger institutions, sometimes they even have spiritual leaders specific to different denominations. So if you are a spiritual person or religious person that may find a visit from a chaplain helpful, that's definitely something you can ask for. And they're often on call as well if there's emergencies or situations that need them urgently. Child life specialists I've mentioned, they're really fantastic. With our kids, they help families and patients navigate the hospital stay, so they can just come provide support. They also have a lot of, therapeutic play options, and sometimes they can even just deliver some toys to your room if you didn't have time to pack up all your kids' favorite things, and provide insights for non-pharmacological pain management. So our child life specialists are in the hospital, inpatient. They're also in our emergency rooms, and they're actually also sometimes able to come down to our blood draw or phlebotomy station in the lab, even just for outpatient lab draws, because we know that can be really challenging. Our dietitians, I probably don't need to talk about how amazing dietitians are to this crowd, but obviously an essential member of our team in managing diet. You'll see environmental services folks coming in to clean the room, clear away any waste, things like that. We have interpretive services. This can range from in-person interpreters, ideally, to phone interpreters. I mentioned there's medical students around. Medical students are usually such an enthusiastic member of our team, and they really have a lot to learn about this group of patients and fatty acid oxidation disorders. So just know that if you're meeting a med student, they're probably going to remember you forever, because they're probably not going to see a lot of other fatty acid oxidation patients in their training. In addition to therapy dogs, there's also music therapists. So there are people that are trained in providing therapy with music. They may play guitar or piano and be able to come to bedside in that way as well. How's my, are you guys hearing me okay, by the way? Okay, great. Sorry, it's like real gravelly today here. Nursing assistants and nursing students. So not only are there medical trainees on the physician side, but your nurse may have assistants and students working with them as well. The palliative care team, I think, is worth a mention in that palliative care specialists can be both physicians. There's also like nurse practitioners, PAs, nurses, social workers. For us, it's a whole team of people, and they really help us when patients have chronic illness and chronic illness symptoms. So palliative care is not just hospice. I think there can sometimes be confusion that if you have a palliative care or someone mentions palliative care, that means that someone's nearing an end of life. That's not actually true. They're actually really helpful in making decisions about goals of care, really with any chronic illness. So they can be helpful for our team too. Pharmacists, also extremely important and a bit self-explanatory. And then phlebotomists are the folks that are coming to draw your blood. Psychologists, I think we're going to hear later today, I believe, about medical trauma, and maybe tomorrow as well. So our psychology team can aid in handling some of the emotions related to hospital stays or behavioral issues in kids. So they may be someone that can help inpatient or also outpatient, depending on the scenario. Our social workers help navigate psychosocial issues, bereavement, adjusting to a new diagnosis. I find our social workers are often really helpful, providing some extra support with that. And they often are the folks that know, where the resources are for things like transportations, hotels, meal vouchers, just kind of physical stuff. And then a lot of hospitals also have hospital school programs and teachers. So if you were in a situation where your child needed a prolonged hospital stay, perhaps worth asking if they're feeling up to it, if the child's feeling up to it, if the teacher could be involved and help liaise with their school as well. And then, of course, another essential member of our care team, inpatient and outpatient, are therapists, our occupational, physical, speech therapists, as well as respiratory therapists. And I think we're going to get to hear more about that today, too. Okay, so you're over the hump of the illness and things are getting better. You're getting closer to discharge. What do you need to know or think about? I think it's one thing could be important to ask is, what are the goals for discharge? So likely the attending physician has in mind what they want to be happening to get you or your kid out of the hospital. And it's often things like back to baseline in terms of eating or drinking or tolerating feeds if there's a tube. Improvement in symptoms. Obviously, if you came in with vomiting, we're not going to send you home if you're still vomiting a ton. Improvement in labs. So if we have rhabdomyolysis, what do they have a number they want that CK to be, or do we just want to see a downward trend? And then maybe able to ambulate back at baseline. So that may not be the exact discharge goals, but if you're wondering, just ask, because somebody probably has a list of things in mind. Here are some questions that I think can be helpful to ask or to have in mind prior to discharge. So are there any changes in medications going on? If so, where are you going to pick them up? Just logistics. Is someone going to bring those medications to the bedside, or do you need to pick them up at your local pharmacy? Have there been any diet changes recommended? Any new formulas or supplements needed? What's the follow-up plan? Often that's going to be something like, check in with your PCP in a week or so. Do you need any other new supplies? And are there any other new specialists, subspecialists, or therapists? And a lot of this stuff will end up on a discharge summary that gets printed and handed to you or put in a patient portal. But if you're not sure, just ask. Okay, so usually when it's finally time to go home, your inpatient team, some members will probably see you that same day. Often the attending will need to examine you before you go. I think, and I will say this, both on the physician side and having been a patient, discharge is never fast. So if you think you're going home that day, you can start asking about it, but it's probably going to take a few hours. Doctors need to finish paperwork. The nurses need to have time to come and educate. So nothing happens fast, but if you do need it to be fast for some reason, just communicate, like, hey, we've got to get to this thing by this time. Is there any chance we can get out of here? Because it can be a slow process. And with that, I'm happy to take some questions before we move on to lunch. Thanks.
Do we have any questions? Yep. And while I'm walking over there, I'm curious. I had a patient recently tell me, who's a nurse, she said, before you leave discharge, request your records so you can review them. So if anything needs to be changed, that they can do that before you leave, because it's harder. Have you ever had experiences with that, or do you have thoughts on that?
Yeah, I guess I would say that's probably most relevant for, like, I would say medications, because that's probably like the thing that if they already sent them to one pharmacy and you hope to have them go to another pharmacy, that's way easier to fix while you're there. Outpatient follow-ups, you can usually finagle those, but yeah, I think these days so much is electronic too, so if you have access to or a way to get on a patient portal, that can be a really nice way to be able to see all that documentation too. Yeah.
Question about the what you mentioned earlier, waiting for in the ER, waiting for orders and specifics, and they may ask you to not eat or drink. Obviously, when a lot of our kiddos get into trouble, we're kind of pushing fluids and different things, even on the way there. And sometimes it takes a while for the IV to be placed. They may not page the geneticist right away. We've gotten into trouble with that where we're waiting and they're telling us not to eat or drink. We've pushed back a good bit about that. Is there a threshold or a point where it's like, okay, I know you guys are saying we can't, but he's literally decompensating in front of us and you're not getting the IV in, where you would say it probably makes sense for us to just kind of push back and go ahead and feed them or give them whatever their fluids are?
That's a great question. I think this is where pairing with your metabolic specialist can be really helpful, in that, like, we're with you usually on that, of like, hey, if Johnny is decompensating and we know his blood sugar is dropping and you guys don't have that IV yet and mom's got Gatorade, I'm going to say give him the Gatorade, right? Like, give them something. So I think absolutely advocating for that, like, with the care team, and encouraging them to call your metabolic doctor. If you feel like you're hitting barriers and they're not hearing you, be like, I need you to call Dr. Pritchard's team right now and explain, what's going on. So, and frankly, sometimes this doesn't happen as much, I think, in our home institutions, but sometimes we see it if our patients have to go to a hospital where they've never heard of an FAOD. It's okay for you to page again and be like, hey, Dr. Pritchard, I'm here in this ER, and they're not listening to me, and I am worried about my patient, because then we can also call that ER directly. Sometimes we get the runaround a little bit, but we do our best. We can call that ER directly and be like, I need to speak to the doctor who's taking care of my patient, Johnny, right now, and help advocate with you. So I think that's one thing we hope to not have to do. We hope people listen to you because you know your child best, but we're happy to help. Yeah.
One way to avoid that a little bit is we actually tell our patients that going to the ER, whether it's ours or outside, is let us know, because then we
Yeah.
will call that emergency room in advance rather than waiting for a potential problem to happen. And take some of the pressure off of you. You should still always be advocating. And I tell my patients, look, if they're not listening to you, call me and hand the phone to them and say,
Yeah.
here's my doctor. Because it's less likely that they're going to ignore us than they are you. I still have them ignore me, but that's enough.
Thanks so much, Dr. Vacca. Yeah, I don't think I said that explicitly, but that's part of why we love to hear from families before or even on their way in. If you're already like, you know what, we got to go in, because then we call the ER, we communicate with them to try to prevent these things.
Can you also talk about if they don't have D10 available, and so that's what the holdup is, what they can give in the meantime until the D10 becomes available?
Yeah, we just say anything with dextrose. What do you got? If you have D5, that's totally fine. Like anything with dextrose. And you're right, sometimes, especially at, smaller hospitals, that is their holdup, is they go, well, we don't have D10 in stock. And if they call me, I say, don't worry about it, get D5 running, we'll get D10 later. So that's a really good point. I think if you as a parent are hearing that, that conversation of, well, we don't have this fluid, then to say, well, then please call, just call our team, the number's right there, and we'll help them navigate that.
So can you explain to me a little bit about like the different levels of quarantine that you get put in? Because sometimes I can't even eat in the room, and I'm like, what happened here? Like, nobody explains that part to me.
Yeah, sorry, what was, I didn't hear that. You said the different levels and they won't let you what?
Oh yeah, like sometimes I couldn't even eat fruit or salad or anything in my room because he was in such a high level of quarantine that they didn't want those germs to be in the room.
Okay.
So I just wanted to know what levels are.
So that specific scenario sounds like I have an idea what that is, but I'll do the general and then, So when anybody's sick, we have different levels of precautions, okay? And so it'll kind of depend on your child's symptoms and or testing that's been sent. So for example, if somebody has a viral illness, they're probably gonna be on droplet precautions. So all the providers that come in and out are gonna mask and gown. If somebody's had just vomiting, but we don't necessarily think it's, a respiratory virus, then we might gown and glove. So those will be labeled outside your room. And it's usually based on either what infection may be suspected or possible, or sometimes, frankly, even if they just send the test for the infection. So if you send a test for a certain GI bug, they're going to put you on precautions until that test is back. So that's kind of what's going on. And you could definitely ask your nurse, like, hey, what are the precautions? For the fresh fruit and veggies, actually, that sounds kind of like a stem cell transplant floor precaution. So I'm not sure. That usually would not be applicable to our FAOD patients, but if for some reason you were in a weird part of the hospital that, because those are patients that can't sometimes eat fresh things like that. I can't really think of exactly why that was going on in your scenario, but that's my best guess. Yeah.
Any other questions? I see, anybody? Do you have one? Okay.
I've heard some parents say that they get prescriptions for D10 and they just kind of have it on hand, like themselves. Is that a thing? Like, how can I get that?
That is interesting. Okay, so I'm going to tell you like my take on that, and then we probably poll the audience. I have never done that for my patients, and the reason is that I feel like if your kid's sick enough that we're in the land of needing D10, I want close medical eyes on them to be sure they're not getting sicker. Oh, like they have a bag with them. Interesting. I've also not done that. I'm not like opposed to that, but I know if somebody hit our hospital with that, our nurses would be like, no way, we can't hang this because we don't know that it's sterile. We don't know where it came from. I'll look at Dr. Vockley, who's, in case he's heard of something different.
I've never done the take it to the hospital routine because I'll just trust the hospital to have some, at least D5 on it. They will have D5.
Yeah.
So you can do that, and as long as it takes them to, usually even with an emergency pharmacy, sometimes it takes a couple hours to get D10 running. So that's okay. Just get D5, run it as fast as they can, and you're fine. I have arranged for some families to have IV fluids at home, and that's a very, very specialized setting, and is done with home nursing availability, a port in place that they can start that. So it's not something we do lightly. If you're home and you need glucose and your child is not throwing up, then just pour it down their throats. Give them whatever you got. Make it as sugary as you can, and that gets in the vascular space almost as fast as your IV fluids.
I was just going to say that a nurse once told me that about someone she knew that had bags of D10 that they took traveling with them, just in case. Yeah. But at the start of COVID, we live in California and have Kaiser, and so they sent us automatically. They just sent us this box of, it's called SOS, and I think it's D20 that you ingest. You drink it. You put in water or whatever else other drink you want, and you drink it, because just in the case of getting sick, to avoid having to go to the hospital when the infection rate was so high, so to avoid going to a place where you're going to get even sicker. And then they did just, it expired, and they gave us another one just in case we get really sick, and we can drink it to prevent having to go to the hospital at times when everybody there is sick. Because my daughter last year was also hospitalized in rhabdo for non-illness, and she got COVID in the hospital. So along the way, so that's why they also gave it to us.
And if you don't have, I think that's a really fantastic tool to have in your toolkit, is something like that. If you don't have that, you're out and about, like Dr. Vackley said, sugar, anything sugary, right? Like frosting, like, yeah, like frosting or cake icing is really high sugar. Things you can have in a pinch while you're getting somewhere else.
Great questions. Any other questions?
Pixie sticks. Dr. Priestley's suggesting pixie sticks. I mean, they're straight up sugar, so. Nice and portable, very lightweight. Yeah. Great.
Well, thank you so much, Dr. Pritchard. Everybody, let's give her another round of applause.
Thank you.